Thank you for attending the second ParkBench positioning workshop. During this workshop, you will review our short video describing the best practice, evidence-based, step-by-step process for the ParkBench position, followed by breakout sessions to practice it hands-on with patient volunteers. It is important to remember that we are doing this as a patient safety initiative to improve standardization surrounding this process. ParkBench position puts patients at risk for several types of nerve and soft tissue injuries. Our goal with this guidance is to reduce brachial plexus and peripheral nerve injuries, as well as pressure injuries such as these. Please be sure to follow along with the ParkBench competency sheets, which will give you further guidance on equipment needs, room setup, and an in-depth explanation behind each step taken. We will begin with the OR bed setup. It is important to ensure that you have the correct OR table as per surgeon preference. Place a Mayfield bracket on the head of the bed per protocol and be sure to replace the headpiece and pad. The Mayfield frame should be attached to the bracket as well. The equipment needed to prep the bed are shown. Dress the table with a disposable OR table cover. Place a long draw sheet across the center of the table. Place the beanbag on top of the draw sheet, preferably with the nozzle on the patient's non-dependent side, or the side that is closest to the door knock, whichever is most convenient and provides the least stretch or tension on the suction tubing. Place a long, flat gel pad on top of the beanbag, and then a second draw sheet half folded should be the next layer, followed by a roll of egg crate foam, followed by a third half-folded draw sheet. There should essentially be 3 layers of draw sheets for ease of patient positioning. A lateral chest wall roll, which is currently a pillow folded in half and taped, as well as extra pillows and arm and leg padding should be available in the room. The strap should be applied to the bed rails as shown, ensuring that the second strap is the longer white strap. For our larger patients, an additional white strap can be placed near the location of the patient's hips, as they usually require additional length to secure the straps across them. You will commonly need 5 to 7 straps total, depending on the patient's size. Once the patient arrives to the room, they should be positioned in the center of the prepared OR bed. The case should proceed with anesthetic induction, intubation, placement of lines and Foley catheter if needed, as well as application of SCDs. Of note, if an arterial catheter is to be placed, the dependent arm is a preferable location for convenience as well as prevention of waveform dampening, which is common in the non-dependent arm in this position. Once all of this is complete, pressure ulcer preventative dressings should be applied to the patient's dependent side directly on the skin. It is important to provide coverage from just below the axilla through to the patient's thigh. Take care to prevent overlap of the padding, as this can actually increase risk of skin injury from shear and compression. Next, the bilateral arms are wrapped with egg crate foam, or they can be sandwiched with foam arm cradles and then taped. Cutouts should be made at the level of the axilla to prevent undue pressure to vital structures there, and any sites of IV or line insertion should be visible or easily accessible for ease with troubleshooting during the case. Lifting help should be available as the team prepares to move the patient into the final position. Commonly, 5 to 6 people are needed for the positioning to proceed efficiently and painlessly. The surgeon should be positioned at the end of the bed and control the patient's head. Pinning the patient can be done either before or after the positioning. We will leave this to the surgeon's discretion. The surgeon should be the lead for this process. The attending anesthesiologist should be positioned on the side of the dependent arm so that they can assist the surgeon in leading the positioning as well as supporting the dependent arm and protecting the endotracheal tube from malposition. The circulator should be on the non-dependent side to assist with lifting the patient's chest. Once the patient is positioned on their side, the circulator can then be freed up to help with the chest wall roll and beanbag suctioning. Additional lifting help will be positioned at the patient's hips, and the in-room anesthesia provider will remain at the patient's feet to ensure that monitors remain applied and that hemodynamics remain stable throughout the process. The process of moving the patient should be done the same way every time. The first step is to move the patient north or toward the head of the bed until the axilla is approximately 2 inches off of the table's edge. Next, the patient is to be moved laterally away from the planned dependent side, ideally leaving about 3 to 4 inches supported by the OR table. This will compensate for the rolling of the patient on their side, which should land them squarely in the middle of the bed. Once the patient has been rolled on their side and centered, the lifting help will shift to the chest and help lift the patient vertically, while the circulator places the chest wall roll and the anesthesiologist continues to support the dependent arm and endotracheal tube. Here you can see a closer look at the positioning of the dependent arm. By positioning the patient's axilla approximately 2 inches off of the bed, it provides enough clearance so that the arm can hang freely without compression. The patient will seem like they are falling off of the bed initially, but when done correctly, they will be centered on the bed as seen on the right. The non-dependent arm will have a tendency to fall toward the head. It helps to place the bed in reverse Trendelenburg position at this point, and to ensure that the up arm is pulled down and secured over the chest wall. A plumb line through the shoulders should be evident. This will allow for much improved surgical access and exposure. If needed, the non-dependent shoulder can be taped in place to ensure this position is maintained. Let's see this whole process in action.
3.
Big lifting my heels up.
You need to come up 2 or 3 more inches.
Okay.
1, 2, 3.
Okay. I'm so strong. Probably more.
Or rolling that way.
Yeah.
So now we need to go over to his right. 1, 2, 3. Okay. Get his left arm out. Let's just roll him up.
You get a little more.
I got the arm and I got the tube.
Let's go ahead and roll him.
Roll him towards me, please. Now the axe roll, which is I heard the axe roll. Yeah. All right. So Carl, we're gonna lift him.
All right. So we move the next roll.
I got a tube.
1,
Yeah.
2,
What are we doing?
3.
Lift him straight up. Axe roll.
Come
Okay,
down.
down. Okay. Put on the legs. Put your legs up here.
There are several things to point out at this time. First, having a leader who communicates each step as the team progresses will be the key to a successful position. Ensuring that someone holds the beanbag and foam padding in place while the patient is shifted is very helpful. The chest wall roll needs to be placed far enough underneath the patient to prevent it from migrating out during the case. And lastly, the chest wall roll gives the patient enough support above the bed to allow for freedom of the dependent arm. It can then be placed in a comfortable position without excessive compression on the Mayfield frame. The dependent arm at the wrist is allowed to rest on the very end of the arm board and secured with tape. Care should be taken to ensure that the arm is at a greater than 90-degree angle to avoid ulnar compression. The upper arm or elbow should gently rest on the Mayfield frame. If it does not reach, please place a pillow underneath it to support the shoulder and prevent stretching or dislocation at that joint. Slightly flex the patient's knees and hips and place a pillow underneath the dependent leg and then another pillow between the knees. The beanbag should be positioned against the patient's body and suction applied to stabilize this position. Check to ensure that there are no pressure points and pad any areas with foam that may be in direct contact with the hardened beanbag. The focus should now transition to securing the patient on the bed. Cover the patient's exposed lateral side with a sheet or foam padding as you start to apply the safety straps. Apply the first and third red safety strap across the chest. Straps that are too tight can impede ventilation and worsen any risk of dependent pressure injury. Be sure that you can comfortably fit 1 to 2 finger breadths between the patients and the straps. The second white strap is then used to secure the non-dependent arm. Again, tightness can be your enemy. There have been several instances of median nerve injury reported, secondary to the position and tightness of the upper strap. The goal is to prevent migration or movement of the arm during the case. You will continue to secure the rest of the body, protecting any exposed areas with sheets or foam, as the straps can cut into the skin or cause shear injury. Tape or tie any unsecured anesthesia equipment to prevent inadvertent misadventure. As you review the final positioning, be sure to assess high-risk areas for appropriate protection, like the hands, breasts, genitals, knees, and ankles. The head will be positioned in pins per the neurosurgeon's discretion. Verify that nothing is compressing the patient's eyes, ears, nose, or chin, and ensure adequate venous drainage with 2 finger breadths between the mandible and the clavicle at all times. A tilt test should be performed. If the positioning has been done appropriately, the patient should not shift to one side or the other. For our smaller patients, it may be necessary to buffer the space between the beanbag and the patient's body with foam. If all of these steps are done correctly, you should have a very happy patient who is free from nerve and pressure injuries. Thank you for watching. You may now proceed to the dedicated ORs for hands-on practice.